So today we are starting a new chapter, that is the Uro-Gynaecology, in which first of all we will talk about the definitions of certain important terms. First one is the irritative symptoms of the bladder, in which first one is the frequency. Frequency means the passing of urine more than 7 times a day. Second one is the urgency. Urgency means the sudden desire to urinate. Third one is the nocturia. Nocturia means the loss of urine during night time, or waking up from sleep during night time more than 1 times to urinate. Next is the urge incontinence. Urge incontinence means the involuntary loss of urine, that is because of the increase in the detrosal muscle contraction. And the stress incontinence is also the loss of urine, but it is because of certain stressful condition or physical effort, that is the increase in the intra-abdominal pressure. Overflow incontinence means the loss of the urine due to over distension of the bladder. And overactive bladder involve a combination of the urinary frequency, urgency, and the urge incontinence. Next is the obstructive symptoms of the urinary tract that usually occur in the BPH, that include the weak stream. Weak stream means there is the decrease or reduction in the flow of the urine. Hesitancy means that there is difficulty in the initiation of the urination. And dribbling means there is a prolongation of the final part of the urination, and patient have slow and trickling of the urine. Now let's talk about the normal physiology of maturation and the continence. Continence means the ability to hold the urine and prevent the urination, and maturation is the process of urination. Normally, there is a balance between the urethral closure and the detrosal muscle activity. The physiology of continence is that during continence there is activation of the sympathetic nervous system, and the sympathetic nervous system causes relaxation of the detrosal muscle, and similarly they also causes a constriction of the internal sphincter and the pudendal nerve. They control the external sphincter, and hence the external and internal sphincter remains contracted, and the urine is held in the bladder. And this is the normal physiology of continence. When the bladder is full and the person want to urinate, then there is activation of the parasympathetic nervous system, and the parasympathetic nervous system causes contraction of the detrosal muscle, and similarly a parasympathetic nervous system act on the internal sphincter and causes relaxation of the internal sphincter, and similarly there is also inhibition of the pudendal nerve. Now, when the pudendal nerve is inhibited, the external sphincter also relax. So when the sphincters relax and the detrosal muscle contract, they will lead to the process of urination. So the parasympathetic nervous system causes urination, whereas the sympathetic nervous system, they relax the bladder muscle, they also constrict the sphincters, so they hold the urine. So and normally the internal sphincter is supplied by the sympathetic nervous system, and the external sphincter that is supplied by the pudendal nerve, and the pudendal nerve is under the voluntary control, means that it is under the control of the person, but the internal sphincter is under autonomic control, and the internal sphincter is normally controlled by the sympathetic nervous system. So the sympathetic nervous system, it is mostly involved in the process of the continence, which means the ability to hold the urine, and the activation of parasympathetic nervous system is involved in the process of maturation, which means the ability to urinate. And during continence, the sympathetic nervous system, they relax the detrosal muscle, and similarly they also constrict the internal and external sphincter, mostly the internal sphincter, and hence the urine is held. But during maturation, the parasympathetic nervous system activation causes contraction of the detrosal muscle, and similarly the internal sphincter relax, and the external sphincter is relaxed by inhibiting the pudendal nerve, and will lead to the process of maturation. Next is the investigation that we do for the urinary incontinence. First include the baseline investigation. So initially we do the urine RE, and by obtaining the midstream urine sample. Similarly, we also do the bladder diary. So the bladder diary is done to maintain the patient input and output record of the fluid, and it is usually adequate when it is done there for 3 days. Next is the pad test. So pad test is done to verify and quantify the amount of the urinary loss, and pad test involve wearing a pre-weighted sanitary pad while performing certain provocative maneuvers such as climbing stair, and during this provocative maneuver we quantify the amount of the urinary loss. And this the pad test is not helpful in determining the cause of the urinary leakage. and the PET test is reliable and reproducible when done per at least 24 hours. So in the baseline investigation, we do urinary to exclude the infection. We do a bladder diary in which we maintain the input and output record, and the PET test is done to quantify the amount of urinary loss during performing certain provocative maneuvers. Next is the imaging. So in the imaging, we do pelvic ultrasound to exclude any pelvic pathology. Similarly, we also do the renal and bladder ultrasound to exclude the incomplete emptying of the bladder, and also to look for any congenital abnormalities such as posterior urethral wall, or any stones or tumor in the urinary bladder. Next is the urodynamic studies. So urodynamic studies involve a group of tests that are used to assess the function of the urinary tract. And urodynamic study, we assess the various aspects of the urinary system, like storage of the urine and the evacuation of the urine. And these tests are not done routinely, because these tests are costly and they are invasive. And the indication for the urodynamic studies involve history of previous surgery for incontinence, if there is a history of surgery for the prolapse, if there are symptoms of mixed urinary incontinence, a recurrent symptom, and similarly if there is neurogenic bladder that occur in diabetes and multiple sclerosis. In these cases, we do advise the urodynamic study. And the most important test in urodynamic study is the cystometry. The cystometry, they tell us about the following parameters. That is, the residual volume of urine in the bladder is less than 50 ml, and a pus desire to urinate comes around when there is 350 ml of urine in the bladder, and the capacity of bladder is around 500 ml. And similarly, the rate of the peak flow rate of the urine is 15 ml per second when the volume of urine in the bladder is more than 150 ml. And the abnormalities that can be detected on the urodynamic studies include stress incontinence. Stress incontinence means the loss of urine due to increase in the intra-abdominal pressure, that is during cupping and sneezing. And detrusor overactivity means there is a contraction of the detrusor muscle during the pelling phase, but there is no leakage of urine. But there is detrusor overactivity with incontinence means that due to the excessive contraction of detrusor muscle, there is loss of urine occur. And mixed incontinence means they include both the symptoms of the stress incontinence and the detrusor overactivity. Now let's talk about the classification of the incontinence. So the urinary incontinence is divided into the stress incontinence, urge incontinence, overflow incontinence, and the mixed incontinence. Incontinence means the inability to hold urine. So in the classification, the first and most important is the stress incontinence. Stress incontinence means the involuntary loss of urine that occur due to the increase in the intra-abdominal pressure that occur during sneezing or cupping, and there is no detrusal muscle contraction. So in stress incontinence, the involuntary loss of urine occur because of increase in the intra-abdominal pressure. And the stress incontinence, which is diagnosed after the urodynamic study, urodynamic testing, is known as dynamic stress incontinence. And now let's talk about the pathophysiology of the stress incontinence. So the stress incontinence normally occur due to the incompetent urethral sphincter. So when there is a rise in the intra-abdominal pressure and the urethral sphincter is incompetent, then there will be loss of the urine occur. And the incompetent urethral sphincter may be because of the intrinsic sphincter deficiency, or there may be hypermobility of the sphincter muscle. So the hypermobility of the urethral sphincter may be because of nerve damage, that is the pudendal nerve damage. The pudendal nerve normally control the external urethral sphincter, and it is a voluntary control of the sphincter. And there may be a loss of the pelvic support due to the damage to the nerves or damage to the muscle. So in stress incontinence, there is incompetent urethral sphincter, and it occurs because of either deficiency of the sphincter or because of damage to the pudendal nerve. The risk factors for stress incontinence include multiple vaginal deliveries, injury to the perineum that occur during post-op delivery, a birth weight more than 4 kg, a macrosomic baby, or there is perineal trauma occur during surgery. The other risk factors that lead to stress incontinence include advancing age, postmenopausal lady, because of decrease in the estrogen, there is a decrease in the laxity of the muscle. Similarly, connective tissue diseases that include Ehlers-Danlos syndrome, Marfan syndrome, and obesity. All of these may lead to the stress incontinence. Next is the presentation of the patient of stress incontinence. So the patient of stress incontinence complain of urinary leakage during running, sneezing, or coughing. So she or he had a loss of urine during performing certain activities, and there are also irritative symptoms there may be urinary urgency, which means sudden desire to urinate. There may be urinary frequency occur, and urinary loss and stress incontinence usually occur in the form of small spurts, and the nocturia and the enuresis are uncommon and stress incontinence. For the diagnosis of stress incontinence, initially we take the history in which the patient will present with these signs and symptoms, and similarly, we will do pelvic examination. We also do the neurological examination. We also do certain tests like urine analysis and culture to exclude infection, and we will do urodynamic study. The most important is the cystometry. So in cystometry, there will be no detrosal muscle contraction, but there is a leakage of urine due to increase in the intra-abdominal pressure. So remember that on urodynamic study during stress incontinence, there will be no involuntary detrosal muscle contraction. Next is the treatment of a patient of stress incontinence. So the treatment options include conservative management and the surgical management. In conservative management, we advise the patient to do pelvic floor exercises. Similarly, we also advise the patient to reduce the fluid intake and reduction of the caffeine intake. And similarly, we do advise the patient the bladder retraining, which means to hold the urine in between the wide prolong the duration in between the voiding. Next is the surgical treatment of the stress incontinence. So surgery is the mainstay of treatment for the stress incontinence, and these surgical procedures include mid-tap urethral procedure, calposuspension, and the periurethral injection of the bulking agent. First is the Calpo suspension. So calpo suspension is done either to open surgery, which is known as birch calpo suspension, and it can be also done by laparoscopy. And calpo suspension involves the attachment of the urethral sphincters to the pubic symphysis. And the aim of this procedure is to elevate the urethral sphincter high in the intra-abdominal location, and it has a cure rate of around 80 to 85%. So in calpo suspension, we attach the urethral sphincter to the pubic symphysis, and we elevate the urethral sphincter. But the complication of this procedure involve difficulty in urination. There may be high chances of bladder perforation. There may be a new onset of the overactive bladder symptom. There may be posterior vaginal prolapse, which is more common in the suspension, specifically the open calpo suspension. Next one is a mid-urethral tape procedure. This procedure involves the insertion of choline tape underneath the mid-urethra, and it is a surgical method of choice for stress incontinence, and it has a cure rate of 80 to 85%. And the last one is the urethral injection. This procedure involves the injection of a bulking agent around the urethra at the level of the bladder neck, and the aim of this injection is to coat the urethral mucosa and prevent the leakage of urine during stressful condition. And the pre-urethral injection are suitable for those women who are unfit for the surgery, or those who are obese and having multiple comorbid condition. And this injection is a cure rate of around 60 to 80%. And the bulking agent that we inject include the macroplastica and the bulkamid. Second one in the incontinence is the urge incontinence. Urge incontinence occur because of the detrosal overactivity, and the urge incontinence is defined as the urinary incontinence that occur due to the involuntary contraction of the detrosal muscle during the filling phase of the bladder. So in urge incontinence, there is involuntary detrosal muscle contraction which causes the leakage of the urine. The causes of urge incontinence include idiopathic. So most of the cases of the urge incontinence are idiopathic, and the cause is unknown. But the risk factors include obesity, smoking, previous hysterectomy, previous continence surgery, and the neurogenic causes, which include multiple sclerosis, spina bifida, and upper motor neuron lesions. All of these factors can contribute to the urge incontinence. Next is the presentation of a patient of urge incontinence. So the most common symptom of urge incontinence is the urgency. Urgency means the sudden desire to urinate and inability to hold the urine. And the patient also complain of urinary frequency, and the stress incontinence is also common in patient of urge incontinence. And similarly, the nocturia in inuesis, they are also common in patient of the urge incontinence. Nocturia means the loss of urine during nighttime, and inuesis is loss of urine during daytime. And both of these are common in the urge incontinence. In urge incontinence, there is a loss of urine occur in large amount without any warning sign. Next is the diagnosis of the patient with urge incontinence. So initially we take a detailed history in which patient will present with these symptoms explained above. Similarly, we do the pelvic examination. On pelvic examination, there may be normal anatomy. We do neurological examination. Similarly, we do urinary and culture to exclude any infection, and we also do the urodynamic study, that is the cystometry. And on urodynamic study, there is involuntary contraction of the detrosal muscle during the filling phase of the bladder, and this involuntary detrosal muscle contraction lead to the urge incontinence. Next is the management of a patient of urge incontinence. So we have conservative option, medical treatment, and the surgical treatment. Medical treatment is the mainstay of treatment for the urge incontinence. First one is the stress conservative management of the urge incontinence. So we advise the patient to maintain a balanced fluid intake, reduce the caffeine intake, reduce body weight, stop smoking, and we also advise the patient pelvic floor exercise to strengthen the muscle. And similarly, we also advise the patient bladder training, means to hold the urine and increase the time in between the urination. Second one is the medical management. So medical management is the mainstay of treatment for the urge incontinence, and the medical management option include advising the patient either anticholinergic or sympathomimetics. And the anticholinergic drugs, they inhibit the parasympathetic activity on the detrosal muscle, and hence they causes the relaxation of the detrosal muscle, and hence they prevent the urination. And anticholinergic drugs that are used, they commonly use include oxybutynin, which act on the muscarinic receptor 1 and 2, 1 and 3, and they relax the detrosal muscle and hence prevent voiding. Similarly, we also can advise the tolterodine, which is a non-selective muscarinic receptor. We can also advise the patient imipramine, which is given during enuresis. And similarly, we can also give the patient desmopressin. Desmopressin is an ADH analog, and it causes the reabsorption of water, and hence reduces the volume of the urine. And the desmopressin is usually advised when there are symptoms of nocturia. So the anticholinergic drugs, they inhibit the parasympathetic activity and causes the total muscle relaxation. And the anticholinergics include oxybutynin, tolterodine, and the other drugs that are used include imipramine and desmopressin. Similarly, we can also give the patient mirabegron, which is a sympathomimetic drug, and they act on the beta receptors, that is the beta 3 receptors, and they causes the relaxation of the dorsal muscle. And these drugs are advised simultaneously with the anticholinergic. And similarly, we can also give the patient estrogen. Estrogen is usually advised in patients that are postmenopausal, and they can be used as a topical vaginal agent for 3 months to reduce the irritative symptoms. So the medical treatment options include anticholinergics, sympathomimetics, and estrogen. The third one is the surgical management. So surgical treatment is the second line, second option for the urge incontinence. And the surgical options include sacral neuromodulation and the injection of the botulinum. And the botulinum is a neurotoxin, and it causes the paralysis of the detrosal muscle. And the action of botulinum injection lasts for 3 to 6 months, and they are repeated after 6 months. And these botulinum injection, they reduces the urgency and the leakage episode by 60 to 80%. But its major drawback is there is difficulty in the urination in around 8 to 15% of the cases. Last one is the overflow incontinence. Overflow incontinence is the involuntary loss of the urine because of the increase in the intravesical pressure. And when the intravesical pressure rises, then the urethral pressure, the urethra becomes open, and there will be loss of urine, a leakage of the urine. So an overflow incontinence is raised in the intravesical pressure from over distended bladder, which exceed the urethral pressure and will lead to the leakage of the urine. The causes of overflow incontinence include decrease in the detrusal muscle activity. There may be bladder outlet obstruction of certain drugs that causes inhibition of the detrusal muscle activity and will lead to the accumulation of the urine in the bladder and causes the overflow incontinence. So the causes of detrusal underactivity include advancing age, decrease in the estrogen in the postmenopausal women, or the peripheral neuropathy that occur in diabetes, B12 deficiency, and the spinal pathologies that include multiple sclerosis and the spinal stenosis. The bladder outlet obstruction that may lead to the overflow incontinence include fibroids, pelvic organ prolapse, urethral structure, and the over correction of the urethra. All of these can cause compression of the urethra and will raise the intravesical pressure and will lead to the overflow incontinence. And the pharmacological causes include ganglionic blockers, anticholinergic drugs, which relax the detrusal muscle and will lead to the accumulation of urine. Similarly, the epidural block and the spinal anesthesia, all of these lead to the overflow incontinence. And the patient present with the symptoms of the incontinence means the involuntary loss of urine. There will be poor streaming occur and there is incomplete bladder emptying because of decrease in the contraction of the detrusal muscle, and the patient will do effort or straining to urinate. For the diagnosis of overflow incontinence, first of all, we will take a detailed history in which the patient will present with the above symptoms. Similarly, we do the pelvic examination, which show normal anatomy. We do neurological examination, which shows decrease in the pudendal nerve sensation, and the urine. We also do the urine culture and the urinary to exclude any infection, and we also do the urodynamic study. On urodynamic study, there will be raise in the intravesical pressure and there will be raise in the residual urinary volume. Next is the treatment of the patient of overflow incontinence. As we know that an overflow incontinence there is decrease in the detrusal muscle contraction. So we will give certain drugs that increases the contraction of the detrusal muscle and will lead to the urination. And these drugs either include the parasympathomimetics, which causes the contraction of the detrusal muscle and will lead to the urination. Or we can also give the patient alpha adrenergic blockers, that is the tamsulosin, which relax the external urethral sphincter and will lead to the urination. And similarly, we can also advise the patient intermittent self-catheterization, discontinue any drug that relaxes the detrusal muscle. And similarly, we can give the cholinomimetics and alpha adrenergic blockers.